Hi, everyone. I hope you're all having a good weekend or whatever day or time it is when you're actually watching this. My name's Carrie Newbold. I'm going to talk about the endocannabinoid system and how it relates to cannabinoid-based medications. So we're going to cover a few things. Certainly we'll start off with where we're at. So what endocannabinoid system is, what cannabinoids are. Then I'll move to a bit of the regulations for the doctors and the health professionals who are watching, and a little bit more about the indications and prescribing and titrating and the like. So let's start with ECS. I'm sure everyone is reducing it down to ECS. It's certainly easier than saying endocannabinoid system 10 times over. So I will do that. Apologies if that's confusing for people. But generally, we're talking about a vertebrate signaling system. So this is something that's been around for a long, long time and has been maintained in all of the vertebrates. We first discovered it, though, only recently. So after a research group in Israel were able to synthesize THC from cannabis in the 60s, it was then that they worked out what system this was impacting on. So really, we've only kind of known about its existence since the 80s. So it's relatively new for us. Generally, we talk about it as a homeostatic system, so something that balances our body. So we speak about it in short form around relax, eat, sleep, forget, protect. So these are kind of what's happening when we're regulating our motor functions, our movement, our thinking, our cognition, emotional responses, motivations, and the like. And it's all over our body. So these little dots denote where those receptors are in our ECS, and it's everywhere. So it's impacting our nervous system, our immune system, cardiovascular system, even within our fat cells, of course. So if we kind of split it up as to what this is, we've got really 3 blocks of things in our ECS. Cannabinoids, the little molecules, the receptors that they act on, and the enzymes that make them and break them down. So cannabinoids, when it's inside our body, we term them endocannabinoids. So endo meaning inside us, and cannabinoids, so the little molecules that are making up our ECS. We know of at least 30 plus, maybe more now, of the molecules that are related to this. That will change. We will know more in the future. The receptors, again, we're only starting to kind of work out which and what are where. So CB1, CB2, these are the ones that are most known about, but there are lots of others that we're learning about each month and each year. And so then the enzymes we're talking about, I won't go into them very much in the next few slides, but what we're hearing about here, or we know about here, is these are short-lived elements. So the endocannabinoids are made when they're needed and they're broken down. And so it's enzymes that are responsible for both of those actions. So if we start with the receptors, so CB1 receptor is the first one we discovered, or humans discovered, and it's the most common, it's the most ubiquitous across our body. What it is really doing, they term it retrograde neurotransmission. So this retro means backwards. So it's this way, a feedback loop effectively of telling us that the transmission has occurred. So if we have our 2 little neurons sitting there trying to talk to each other, our action potential, our electrical signal, is going down that first neuron. It then lets a neurotransmitter, a little chemical signal, to go across the gap, so between the 2 nerves. Then when that happens, not only does that trigger an action potential in that second one, it also triggers the production of endocannabinoids in that second neuron. So when that happens, they go backwards, this retrograde business, across the cleft again, across the gap, which then regulates, which turns off that neurotransmitter. So it's a way of our body saying, okay, I got that signal. You don't have to keep telling me, stop now. So it's that backwards loop business. Now, CB2 receptors are on cells that are any cell, any tissue, any organ that's associated with our immune response. So the ones we know of already are microglial cells in the brain, neutrophils, mast cells, macrophages, monocytes. So lots of the white blood cells, the ones that are involved in our immune response. And they've even discovered them recently in neurons in our brain. So they, again, that image about with the person with all the dots, they're all over our body. What these guys do, the CB2 receptors, are upregulated in response to insults. So insults is any injury, any immune response. So when something's going on in our body, our CB2 receptors start talking. What they'll do then is modulate our cytokine release. So cytokines are a little molecule, a little chemical messenger that effectively gets released by a whole pile of cells, a whole pile of immune-related cells, to tell people that something's going down here and they need some help. So this modulation, this increasing, decreasing, usually decreasing response, helps to manage how much immune response we're getting. So CB2 is mostly around the immunosuppressant, so reducing inflammation, reducing pain. Now, if we go back a step and we go to these little molecules, the endocannabinoids, I mentioned earlier, it's a brief life. So they're made and broken down within minutes. We don't store these guys, we make them to use. So a few, I've added a chemical picture just because it's beautiful, but we will not be testing you at the end. Anandamide's the first one that was discovered. So this is named after the Sanskrit word for bliss, and what they term, it's around this, like the runner's high that we know about. This was first thought to be endorphins, but now actually we're starting to realize, oh no, that's anandamide that's involved with that and responsible for that. And this is a partial agonist for CB1 and CB2 receptors, along with a whole pile of other endocannabinoid receptors. 2AG, I'm not even going to pretend to tell you the whole line of this, arachidonic, blah, blah, blah. It also is a full agonist for CB1, CB2, along with other cannabinoid receptors. PEA is another one that you might have heard of, or you may come across in the future. So it has analgesic and anti-inflammatory activity, and already is commonly prescribed as a molecule itself for chronic pain management. So there's more than one way to help our own ECS. So we know of cannabinoids, and we're going to talk about the phytocannabinoids in a moment, but that's not the only way. So we're starting to realize that a whole pile of pharmaceuticals that have what we hope were other reasons, or we knew earlier that there were other ways that these are working, but we're starting to realize these guys are also impacting our endocannabinoid system. And then there's other things that we can do every day on top of the medication end that we can support ourselves. So we make our endocannabinoids. So this means that it's really important as to what we eat, so we've got those building blocks, but also that we're not impeding our ability to make endocannabinoids. Lifestyle, so exercise, I touched on the runner's high before, but there's other lifestyle factors that can impact positively and negatively what's going on for our ECS. Herbal remedies, so there's extra things that we are always eating, so black pepper, other terpenoids, echinacea. There's lots of elements that are, if with healthy lifestyles, we are impacting and eating. And then stress. So it's absolutely, when we're talking about relax and protect, these are all things around our sense of stress, our chronic stress. So activities and treatments that support our ability to relax and rest are also going to be supporting our endocannabinoid system. So we touched on this before. When we using phytocannabinoids and even our PEA, for example, but taking exogenously, taking it as a tablet, this is where it's impacting. It's going directly on our receptors. Whereas the lifestyle changes, so the exercise, the diet that we're eating, this can potentially be impacting our endocannabinoid level. So it kind of comes in at a different level. Both are important, but it's attracting a different activity, a different response. So we go more into phytocannabinoids. So phyto means plant. So these are cannabinoids that come from plant sources. So cannabis is the one that we most know about. We know now, I think we're up to 500 plus compounds inside our cannabis plant. And they will vary depending on what the genetics and also the growing conditions of those plants. But there's kind of three main groups of molecules. So we have our terpenes, so the ones that are associated with the smell. Terpenes are in most plants. So if you can smell a plant, that's a terpene that you're smelling. Flavonoids are around the color, and cannabinoids, this is the molecules that we're often mostly interested in, are the ones that bind to our endocannabinoid receptors. We originally thought that were the only ones, but now we're starting to realize that some of the terpenes are doing it. So the black pepper I mentioned before, so beta-carotene, that terpene, inside black pepper, inside cannabis plants, also what they call it is a dietary cannabinoid. So it will also bind to ECB receptors. Together, it's very much the sum of the parts do more kind of thing. So this entourage effect that you perhaps may have heard of, this is this idea of just that singular cannabinoid by itself is good, but taken as a whole, taken with all these extra little elements, is even better. I am not going to list the 150 plus cannabinoids that we know of so far. THC and CBD are likely to be the ones you've heard of before, and they're also the ones that in the plants that we're growing these days are the most common, most prevalent molecules in the plant. But they're not the only ones, and as research increases, we're going to learn more about these extra ones, the CBN, CBG, but at this point, it's certainly easy for us to access CBD, THC as molecules, as plants, as medicinal products. And so these are the ones we most know about. So a little bit of idea of what they do. So THC, this is the one associated with the psychoactive properties. This is the one that, from a recreational perspective, all the plants have been like pushed to grow more of. This, yes, that it has the euphoria component, but it also has some really important therapeutic aspects: analgesia, appetite stimulant, antiemetic, relaxant. So these, taken in the right dose, can really be supportive for people with different indications. CBD is the non-psychoactive component, so it can even modulate the psychoactive effects of THC rather, given in different proportions. But by itself or of itself, it has anti-inflammatory, antioxidant, and anxiolytic, so reducing anxiety components. So it's a regulated molecule in Australia, or group of molecules, plant in Australia. So the scheduling is important, particularly for the health professionals among you. So generally, if a cannabis or THC in Australia is packaged or prepared for therapeutic use, we term that S8. So it's a controlled drug, you need a prescription, you need to store it in particular ways. You know, there's all kind of layers of requirements for that in terms of access. Then pulled from that is the subgroup of CBD. So CBD, the TGA has realized, actually is a really innocuous molecule, and actually given still within prescription mode, when it's 98%, they've sort of deemed that as a separate category, a separate scheduling. So that's scheduled S4. So you can get a prescription from your doctor, and usually you require less permit requests. There's been a new scheduling available for a subset of that CBD. So when it's orally prepared, when there's a maximum of 150 milligrams of CBD a day, there's other little dot points as to what this is, but it also has to be, this product has to be listed on the ARTG, so our Australian Register of Therapeutic Goods. At the moment, there are no products on that. So while this will happen in the future, so say next year or the year after, which will mean that we'll have this S3, means pharmacist only. So this is like going into the pharmacy and just ask, you don't need a prescription, you can just ask for the pharmacy to get it from behind the counter. That's this kind of scheduling, this kind of medications. So we're not there yet, but that will happen in the future. So generally, how does it sit in Australia? How are we regulating this? So at the top, we've got Office of Drug Control. So this is like any kind of manufacture, growing, importing, etc. That's all controlled and overseen by the Office of Drug Control. Then in terms of patient access, we've got the Therapeutic Goods Act. So this for humans particularly, so not so much for animals and veterinary products. We have the TGA to support us for manufactured goods, manufactured products. And then each state, so I've put Victoria here because that's where I'm sitting right now, but each state has their own level of control in terms of the prescribers' access. So prescribers, depending, and it's usually around S8, so the THC, the cannabis level, they'll often need an additional permit to prescribe those medications. It's changing all the time, of course, as this is a relatively new field. It was only accessible to us from 2016. So the expectation is that as we get more used to it, as we get more understanding, these regulations will change in time too. So in terms of what kind of products we can be prescribed, we have two cannabinoid-based medications that are on the ARTG that are all like effectively approved products. So you don't need an extra TGA approval or anything, but you can the doctor can prescribe it directly. So that's Epidiolex, which is effectively 100% CBD, and Sativex, which is 1-to-1 CBD THC, both oral formulations. And then we have the middle group, so this unapproved products. So these are manufactured products that have either been made in Australia or imported into Australia that you can access via the special access scheme. So this is the doctor doing this. This is the patient. The doctor will do this for every patient. The authorized prescriber scheme, or as part of a clinical trial. So again, the patient doesn't have to be involved in this, but it is prescribed and approved per patient on a case-by-case basis. And then the other option, again, is compounded formulation. So if ever a doctor wants to create a formulation that's specific to that particular indication, that's not available in one of the, I think there are almost now 200 products, manufactured products in Australia available via the SAS process, you can certainly compound it. So these need still the same import license, TGO, T93, 100, etc., as you would for the manufactured, but they need to be made individually for that patient and under controlled methods, as with any compounded material. Okay, so what are we talking about? What indications are we dealing with? So when it first became accessible for patients to access cannabis-based products in Australia, the TGA put out 5 guidance documents for specific indications. So this wasn't saying that the TGA is approved for this. Okay, yes, no worries. If you've got any one of these indications, you can go for it. It's more have a look here. There's a good amount of information for these indications. Have a look here and see if that's relevant for your patient. So in Australia, the access is case by case. So if the TGA is leaving it to the practitioner to decide whether it's relevant for that person or not. So usually what we're talking about is when people don't respond to typical medications, they don't tolerate the typical medications. It might be that they've got on a whole, group of different pharmaceuticals and they would like to now start reducing it. So example, in the opioids and reducing it down with CBD, etc., and supporting quality of life. So that's not just palliative care per se, but even with other like long-term conditions, we want to be able to support the symptoms that the patient is going through. And we of course have lots of indications that might be relevant to. So chronic pain, insomnia, epilepsy, when we spoke about how all over our body this endocannabinoid system is impacting, then it's of course no surprise that we've got a huge list of indications that have been approved already for specific patients by the TGA for these medications. Okay, so as with every medication, it's not a free option. There's always a risk, there's always contraindications. So for CBD, I've separated now CBD, THC. So for CBD, the adverse effects that might occur often, most usually, is around the dry mouth and gastrointestinal stuff. So not always, but often CBD is provided in oral form and often mixed in with oil. And so then as your dose increases, you're also getting far more oil, and that can cause upsets for people. The other bit that's important to note is signs of allergy. So as with any medication, it may not be that they're allergic to the active ingredient, but it might be that you're allergic to anything else that it's been delivered with. So not common, but important to consider. And as I've got this on the next one as well with THC, but as with all of this, adverse effects is a sign you're potentially increasing the dose too quickly. So it may be that you want to slow it down, decrease it, stabilize a little, get some tolerance before you're moving upwards. So same game for THC, same kind of gastrointestinal, particularly if it's been an oral formation. But of course, because of that psychoactive component of THC, there's other indications that, other adverse effects that might be felt, particularly again, if that tolerance is not built up initially. Contraindications. So for both of these ones, the hypersensitivity to either cannabinoids or the other products, the other elements in it is important. And then the other, bigger category, the impact on the cardiovascular function. So THC and even CBD to some extent can dilate the blood vessels. And so if there's a severe or unstable cardiopulmonary disease, then that's a real red flag in terms of whether you want to try these particular medications or not. And if they are, you're really wanting to be supported and watched and really taken through this. For THC, due to that psychoactive component, the extra contraindication there is psychosis or inactive thought disorder. a previous one or everything, that might be a maybe, a yellow flag, but it may not be a red flag. Whereas something that's happening right now, it may be that there's other medications that are more suitable. Pregnancy and breastfeeding is a common one for most contraindications. And again, it may change over time, but at this point, these are not the groups that are being assessed in the early days. Epilepsy and regular seizures, this is an important one for THC. So it often with epilepsy and with seizures, a small amount of THC given with a lot of CBD can be okay, but the opposite is really not necessarily appropriate. Liver and kidney disease, as we'll talk about in a moment, the metabolism and the excretions around these organs, so a well-functioning or at least not completely dysfunctioning liver and kidney is important for this. And balance issues. So for THC particularly, if any dizziness is occurring, what we don't want is if someone getting dizzy, falling over, breaking their hip, that's not a helpful option. So that's a really important one to consider, particularly for patients who are living by themselves and may not have the support they could need in times like that if they dose incorrectly. So same game for CBD. So now in terms of the major contraindications, we're really just left with, are they allergic to any of the elements? But then there's some relative contraindications, same one as previously, pregnancy or breastfeeding, liver or kidney disease, heart problems, elderly, so balance issues, etc. Okay, so interactions. So generally what we're talking about is the cytochrome P450 enzyme system. Lots of medications are metabolized using this enzyme system, so there are a lot of potential interactions. I've just added the link to our prescribing handbook if you would like to have, for prescribers to have more information in terms of where the interactions are, where there's increasing or decreasing in terms of dose. Certainly please do contact us for that. Otherwise, what we're talking about here generally is metabolized by the liver, excreted by the kidneys. The other bit that's useful to know, particularly for THC, it accumulates in the fatty tissue and it's released slowly over time after that. So even from a single dose, it can take up to 5 days to excrete the total dose. So it's just an important one to consider in terms of long-term impacts for driving and things like that. So other interactions, just from a broad sense, warfarin is a really important one to consider. So that can sort of increase, there's an interaction there. So warfarin levels can be increased effectively or perceived to be increased in the body. So regular INR monitoring is important. So generally the interactions are kind of grouped into 4 main areas. So sedation. So if patients are being co-administered with other medications that cause sedation, really consider if there's going to be an additive effect and look for that in terms of dose management. Same as those with antispasticity agents and any cardiac medications in terms of that additive effect as well. There has been case reports of hypomania with other medications. So again, those 4 areas in terms of sedation, musculoskeletal, cardiac and psychiatric are really important to just watch that that's being managed appropriately for your individual patient. Okay, so dosing guidelines. This is like a 10-second intro, so it's very much an intro. I think from a patient perspective, see your doctor, absolutely, and go back to your practitioner each time to see how that's going to work for you. And then as a practitioner, definitely work with other organizations who can support you on that and learn. There's a lot of really good cannabis clinicians in Australia, and they're all really giving of their understanding. So definitely connect with them for more information. But generally what we're talking about here is there's an individual response. So it may be what works for one person is not necessarily going to work for another. And the other aspect is where they're up to. So in the pictorial that I've put to the side, we've kind of grouped this whole ratio of, you've got ones that have high CBD, low THC, and other medications and other indications that are, flipped. So high THC, low CBD. So we have a bit of an idea of where things might lie, but already these things are starting to change in terms of our best understanding, and also where some person starts or ends and finds benefit will be different from the next person. So again, it's very much, and the TGA kind of talks about this, it's a trial. So for each individual person, you're trialing to see if this works for them. And so it's really important to watch to see how or not it might be working. So as with some other medications, titration is a really important component. We touched on it earlier in terms of the side effects, the adverse effects. But what we want to know is, where's that spot for that person? So we start at the low end. We start often for the clinic that we work with, it's starting with CBD often, and then building up as we need to, moving into THC as we need to, because it may be that we don't need to. But the start slow, increase slowly, stay low is a really important concept to keep in mind across the board. So in terms of monitoring your patient outcomes, you can block it into 3 things. So looking at the symptom control. So the reasons why the patient wanted to try this in the first instance, are they being impacted? The goals that they were after, their measurement of success, is that changing or not? And then watching for adverse events. So this is not just in terms of that particular medication, the CBD or the THC, but also those interactions. How is that impacting the dosing requirements of other medications they may be on? And then some of that, we might be able to see in terms of an adverse effect. Others we may not be able to see. So pathology monitoring, particularly for liver function, is really important, or can be really important if that's relevant for that patient. But I want to leave you kind of with this last concept of this is what we know now. And, in 10 years time and 5 years time and potentially even next week, it will be different. So the one thing that I know is constant is this fact of change. So please do expect change. We will, as this idea of homeostasis and bringing it all into the center, we will get there. We're still in a learning stage at this point. So thank you for this. I hope your own journey as a clinician or as a patient is bright, and we look forward to speaking with you guys again soon. Thanks.